Hi everyone, welcome to Lection 4, where we're going to talk about adaptive behavior and its assessment. The previous lecture we talked about intellectual functioning and how we assess for it, and now we're going to talk about the second piece of that operational definition in one of the 5 areas of human functioning. This piece is really important. If you remember from past lectures, I've talked about how this can be a little difficult to measure, however, has really emerged as a crucial part of the definition both across the operational and the multidimensional framework or the constitutive definition, in that this is where we plan for supports. This is what gives us information about what we can do to make things better and to really help maximize human functioning. So adaptive behavior, it's defined through the definition as when we're looking at intellectual disability in that context as a significant limitation in adaptive behavior. It needs to be established through also the use of standardized measures. Just like with IQ, it needs to be normed on the general population, and that includes people with and without disabilities. When we're looking at deficits in relation to a definition, we need to see significant limitations in adaptive behavior, as also 2 standard deviations below the mean of either, there are 2 separate things. So one of the types of adaptive behavior, so that those conceptual, social, or practical domains, or an overall score. So when you take an adaptive measure, you'll also get a general adaptive composite usually on a standardized measure of conceptual, social, or practical skills. And just like with IQ, the standard error of measure needs to be taken into account. So what is adaptive behavior? So the first area is conceptual, and these are all the different things that pertain to the conceptual domain. So things like language, so expressive and receptive language, expressive, how you use language, and receptive, how you understand language, reading, writing, basic money concepts, knowing how to make change, how to use a clock and tell time, in addition to basic number concepts. The social domain, this is really important and can be the most difficult to measure because it's hard to directly measure it. But these are interpersonal skills under having social responsibility, self-esteem. The gullibility and naivete piece pertains specifically to our population because it's an area we commonly see deficits in across all individuals with intellectual disability. And deficits in these areas can allow individuals to be victimized or taken advantage of and and deficits in this domain can lead to a lack of social problem solving. So knowing when someone's kind of trying to trick you or take you for a ride. And the last domain is practical. So these are activities of daily living like personal care, like bathing, brushing your teeth, those types of things, occupational skills, use of money, safety, health care, transportation and travel, using a schedule or routine, and also with using a telephone. So how do we assess for adaptive behavior? You want to make sure that we're using a standardized measure, just like when we are assessing for cognitive abilities. And, sorry, I have to keep moving this around so you can see everything. Move it down here. When you get a score, you want to also know what the standard error of measure is. And especially with adaptive behaviors, this varies greatly depending on if you're measuring social, conceptual, or in the practical domains. And they also, the standard error of measure varies greatly also on the age of the individual. So it's best to making sure that you're using the standard error of measure and then you get a good confidence interval for that. A huge difference between measuring, or probably the biggest difference between measuring adaptive behavior and intelligence, not necessarily between the 2 constructs in general, is that there's this focus on typical performance. And I've talked about that before, but we're measuring IQ, we're looking at maximum performance. But when we're measuring adaptive behavior, we're really focusing on typical performance. So for example, brushing your teeth. Now, some of us may be better than others and maybe remember more often than others, but there's not someone that can be the best ever at brushing their teeth. There's a general minimum standard of performance based on your age and how much assistance you require. So when we're looking at adaptive behavior, we're just focusing on what a typically developing individual that age should be able to do independently. Also, a really important consideration when we're looking at adaptive behavior is using knowledgeable respondents. You want to make sure that you are getting information from the individual themselves, but also they may not be the best reporter of their adaptive behavior. So it's heavily reliant on third parties, so family members, caregivers, people that know the individuals really well, and making sure that those people are valid and reliable reporters so they can appropriately report on an individual's level of performance. So it's really helpful to get information from multiple people and from multiple sources. And most of the adaptive behavior measures have different versions. So for like school-aged individuals, there's a school and a home version. There's also like a home version and a work version on a lot of them for individuals that are in the adult years and may be employed. So there are sometimes, though, you can't use adaptive behavior measures. Because, and just you can pause for a second to think, well, when will you be able to get a good respondent? There could be, the individual could be older and they're getting a diagnosis later in life, and maybe they don't have family members that are alive, or they don't have enough people that are reliable informants. So in that case, the use of school medical records, so past history, observations that a individual can take, watching an individual performing typical areas, or performing tasks at school or at work or at home. Previous evaluations may be able to give information about what an individual is or is not able to do in the adaptive domain, and then also interviews with the individual. Some general guidelines, though, when you cannot use adaptive behavior measures, is to make sure you use multiple sources, so as many individuals as possible. Again, you're measuring qualitative information, though, so they should be interpreted with caution. And remember, anytime you do an observation, that represents one sample of behavior of that person at that point in time. So making sure you get multiple observations. Clinical judgment on the reliability of the reporter, making sure the person can accurately give you a good picture of that individual. The person may not know the person well enough, and so making sure that you feel like they have enough information to be a reliable reporter of the questions that you're asking. And make sure your method is accurate and pertinent. So, and we're talking about pertinency, we're making sure that it's we're understanding the context of the individual. So if you're looking at their adaptive behavior at work, making sure you're getting information from employers or observing them at work, not just at home. And so making sure that it's pertinent to what you're actually looking to assess and in what area of adaptive behavior you're looking to assess. So now we're going to talk a little bit about various supports that are available for adaptive behavior. And when we're looking specifically at evidence-based practice, this information in the second part of this lecture is taken from your supplemental text. When we're really looking at chapter 2 with how we measure adaptive behavior, and also what we can do to make adaptive behavior deficits stronger across certain domains. So the biggest thing is early intervention. Early intervention can take place for an individual who are at risk for disability. So maybe they have general developmental delays, so we intervene early, so maybe they won't meet criteria for diagnosis later on in life. Or we know somebody is born with Down syndrome, for example. So let's intervene early in some areas of adaptive behavior so the impact of their disability isn't as great later on in life. The goals of early intervention may include acceleration of the rate of development, this can be shown in changes in their adaptive behavior measure, and also specific domains, so the use of speech-language therapy or pre-academic skills that can really help strengthen those things, and then again, lead to the decrease in need for services later on in life. The main rationale for early intervention includes really just helping current, existing, or preventing future disability. So giving children a developmental advantage when they go to school, and potential benefits to parents, such as reducing stress or burden or care. Early intervention also really has the potential for large savings, right? So if you intervene early on, maybe you won't have to have such expensive or more in-depth services later on. So it's really, really important, and the evidence shows that early intervention is amazing. However, if you look again, there's not really this perfect age as to what you need to intervene. We just know it needs to be early. If you provide supports early on for adaptive behavior, this can really impact the need for institutionalization in long term, which again also has a cost benefit. Some examples of early intervention for adaptive behavior are social skills training. This is an evidence-based intervention, and one of them is video modeling, where the individual makes videos of themselves performing tasks that are appropriate, and then they watch them. For increasing language skills, the use of behavioral principles, so rewarding an individual when they show certain things and having really specific goals and contingencies. The use of augmented assistive communication devices, and also PECS, which is a picture exchange system that can be used to help individuals communicate. Additional evidence-based practices for adaptive behavior are staff and parent training. This can help improve child outcomes, but must be cognizant that the program that you're using is evidence-based. There are many evidence-based programs out there. In your chapter, we'll talk about some, but really making sure that one of those is picked and one that doesn't have evidence. Self-management, this can be really effective for children and adolescents with autism spectrum disorder specifically and intellectual disability. Peer tutoring, there's a lot of support for the 2T, so the person that's being tutored. So really using an individual's peers to help help them learn. So instead of having a teacher do it, maybe having a student that has grade level reading skills tutor a student that has difficulty reading. When we're looking at psychotherapy, evidence-based practices and increasing adaptive behavior has been shown to be beneficial when you're teaching decision-making and problem-solving skills. When we're looking at purchasing, money, and mathematical skills, there is evidence to support that if it's done in vivo, so like in the moment and in the context of purchasing, it can be really helpful in addressing adaptive behavior deficits in that domain. Exercise, this really helps with motor skills. They have the most impact. That's what the evidence suggests. And that can really then again help access to different leisure activities they might want. Social stories. The evidence is a little bit mixed on social stories. So there's little evidence for this for individuals that maybe have severe learning difficulties in addition to an intellectual disability, but does seem to be beneficial for people that have social and emotional difficulties. Special education placement as used as a support for adaptive behaviors could be effective. Again, the evidence is not as strong for this, but it could be effective in contributing to help with vocational or employment outcomes long term for individuals with disabilities. All right, and so now I want to talk a little bit about problem behavior versus adaptive behavior. So I want you just to take a second, pause if you need to think about what's adaptive behavior and what's a problem behavior. And the two are interrelated, but they're very different things. So take a second, pause if you need to, but think about, now what do I think an adaptive behavior is and what's a problem behavior? And what's the similarities and what are the differences? So if you paused, welcome back. If not, it's important to note that an adaptive behavior is something that helps get us through life. And what can happen sometimes is a problem behavior or a non-desired behavior can arise due to a lack of an adaptive behavior. So for example, think about an individual who's aggressive, right? So that individual, that would be a problem behavior, but it might have come up because of a deficit in adaptive behavior, such as a language skill. So if a person can't communicate effectively or have an effective communication system in place, that would be a deficit in adaptive behavior that has led to a problem behavior. So the two things are very similar, but it's really important to make sure you understand the difference and see sometimes where problem behaviors can crop up if adaptive behaviors aren't planned and supported appropriately. When we're looking at just the co-occurrence of two independently, the relationship between the two are generally low. So just because someone has a deficit in adaptive behavior doesn't mean we're going to see a lot of problem behaviors, or we most think of aggression or self-injury. But it is higher in cases of severe intellectual disability. And a lot of times that's the case because it's difficult then to determine the function or the reason for the problem behavior. And it's difficult to put a more adaptive behavior in place. So to note here, behaviors that interfere or limit daily activities are problem behaviors or maladaptive behaviors. So things that kind of get in the way. And it's really important that we then consider the function of problem behaviors to help develop good adaptive behaviors in their place. Because anytime you take a behavior away from a person, so aggression or something that's working for them, you need to put something else in its place so the problem behavior doesn't crop back up. All right, here are some different examples of maladaptive behavior that we see in individuals with intellectual disability. And we're going to talk a little bit more about this in the next lecture that's specifically going to focus on aggressive and self-injurious behavior. But some examples, the first one is self-injurious behavior. So these are things like hitting yourself, biting self, those types of things. And there is support for behavioral treatment in this domain, so that follows basic ABA principles or behavior modification principles. And so that's really important to consider. Pica is eating things that aren't edible. Again, positive behavior supports and behavioral principles have shown to be most effective for reducing pica behaviors in individuals with intellectual disability. Disruptive behaviors, this is any excessive behavior that can interfere with someone's daily life. This could be noncompliance, throwing things, those types of stuff. This is important that behavioral principles, this is a common message, some type of comprehensive behavioral treatment package should be used. But it was shown that differential reinforcement schedules and token economies, so giving someone something tangible when they don't show disruptive behavior, were most effective. And then lastly, when we're looking at compliance, so following someone's directives, it's really important that behavioral principles, again, are followed. That's an evidence-based practice for this. But it needs to occur right after you see compliance. So I'm talking a second or two, not later on. So it's making sure that reinforcement is occurs very soon thereafter. And in general, all treatments, specifically behavioral treatments that are evidence-based, work best in younger children than in adults for achieving compliance in this population. All right, so general interventions for maladaptive behavior. The first is positive behavioral supports. This has good support again across the literature for multiple populations, but positive behavior supports, they're used a lot in schools now. So if you work in schools, you've heard of PBIS. So these are things that really just they set the environment up for success for the individual. There's very clear rules, expectations, contingencies, and reward systems. These are really, really helpful in general, and it's a really good first line of defense as an evidence-based practice for addressing maladaptive behaviors. And then cognitive behavioral interventions. These things, again, are a little bit mixed, but they do have an evidence base when we're looking at anger and controlling anger for individuals with intellectual disability. Again, they're not perfect, but they definitely have the most support currently when we're looking at addressing specifically anger as a maladaptive behavior for individuals with intellectual disability. So that was adaptive behavior, how to measure it, and the difference between adaptive and maladaptive behavior. If you have any questions at all about anything that was in here, please let me know, and I'll be happy to clarify. Thanks so much.